Hello, everyone, and welcome to this ultrasound webinar with Rick Meece. I'm happy to have you all here for this educational program. My name is Keith Fox. I'm the Cardiovascular Ultrasound Learning Program Manager for North America, and it's a pleasure to present this opportunity on behalf of Philips Ultrasound Education. I also want to let you know that in the background, my colleague Deb Agler is the wizard behind the curtain making all the technology happen, and I appreciate her efforts. A couple of matters to address before we begin the presentation with Rick. Due to the large number of attendees, we will have all participants on mute throughout the presentation. Please stay on mute throughout the webinar to avoid distraction for the other attendees. Please place your questions in the chat box throughout the lecture. After the lecture is complete, we will address as many of your questions as possible with Rick during a question and answer session. Due to the number of attendees and questions we are likely to receive, we may not make it through all of them, but I will attempt to identify as many unique and pertinent questions as possible. I want to thank you for understanding. All right, well, Rick, I'm going to go ahead and stop sharing and let you take over, and I look forward to hearing your presentation.
Hello, my name is Rick Meece. I'm an advanced cardiac sonographer and also invasive cath lab technologist, and I've been asked to create this webinar on echocardiographic assessment of myocarditis. First, I'd like to just thank Philips Healthcare, my good friend Keith Fox, who's the learning program manager, and then Debbie Agler, my colleague, who is the clinical services specialist and also a coordinator for the virtual learning so that this could actually take place. In terms of some colleagues I reached out to, I just want to thank Jeff Hill from MCPHS University up in Worcester, Richie Palma, who's now at Duke, Dr. Sanjita Saw at Ochsner, and Elizabeth McIlvain in New Orleans. Some of my background, I spent the last 23 years at St. Thomas Hospital in Nashville, Tennessee, and also in another hospital before that that is actually both owned by Ascension Health. And so I have 30 years in echocardiography, and then also 12 years full-time as a cath lab technologist, and we were a very high volume interventional center. So I've just had a blessing of being very experienced on both sides of the cardiology environment. I also spent 10 years primary clinical echo research and did a lot of work with heart failure, 3D echocardiography, emerging tools, and cardiac resynchronization and myocardial mechanics. And then the last 10 years, I did primarily echocardiography as a specialist in assisting and teaching in perioperative, and then all the new structural heart and device research along with hybrid imaging. So I've just lived in a good time, and I've been very lucky. My disclosures are I am on the Speakers Bureau for Philips Healthcare, and I do get some research support and advice from the great team at TomTech. So what are the objectives for this? First, I just want to make a note of probably the most important thing that's come out recently in echo would be the recent COVID-19 ASC safety guides. And I'll point you to the right direction for that for anyone viewing who may not have already interacted with that information. Then we'll just talk about myocarditis in a normal world. Now it's a little different with this virus, but we'll talk about it as a global subject matter. So we'll look at the clinical biomarkers and some of the etiologies for myocarditis. We'll talk about some of the primary imaging methods, again, in a normal world. And then what are some of the echo imaging options and what would be useful or even needed to help, correlate some of the biomarkers that they look for to determine myocarditis, the presence of it, and the cause of it. And then in an imperfect world that we're in now, what would be a suggestion for a potential rapid acquire echo approach for both initial and serial follow-up using offline analysis in patients suspected for myocarditis? And we'll talk about the right rules of the game to do something along those lines. So some of these resources I mentioned, this was, I believe last week, This address at the top, I think hopefully most of the people viewing this are familiar with, of course, the American Society of Echocardiography. And if you go to the main page, asecho.org, you'll see a big link probably on the main page that says COVID-19 resources. And so here we have a statement on safety, protection of the patients, protection of the staff, appropriateness of what to image, how much to image, and why. In the current era of everything being affected by the presence of this virus and what's appropriate. So I won't go into a lot of the details on it because you need to look at the document. That's why I have this on the very front end of this presentation. Within that same page, they have a nice flow chart in terms of what they deem appropriateness and then what type of PPE or PE they would use to perform certain exams and whether they would perform them or not. And then on top of that, which I would recommend even more strongly, once you reviewed those documents, they now have posted a video. This is a presentation. It's Dr. Swaminathan from Duke here that was really, really well done. And you can access this. There's probably a link on the ASE page by now, but there's an address on YouTube. I'm sure if you just typed in ASE COVID-19, more than likely you would find this on YouTube. You really need to watch this video because this takes those documents, puts them into real time with interactive communication and conversation between all the people listed here. And it's just can't really be improved on. You really need to view this video, and I think you'll all your labs will benefit greatly. And then as a backup for possibly if any physicians see this presentation, as it will be open source, there is a very, very good video here with Dr. Alida Caforio and Barbara Casade. I'm not sure if that's right, but I'll give her my apologies. This is a very good video from the ESC perspective, cardiac complications in COVID-19 myocarditis, and they have a lot of insights on what little is known and certainly more appropriate for you to get this type of information from physicians on the ground who are the experts. I try to be knowledgeable, but I realize I'm not a physician, so we'll just leave it at that. So just some of the key points, just so I'm not completely skipping over it as part of the presentation, because we'll probably readdress this a little bit towards the end of this talk, is one, it would be obviously with these patients being active or positive, they want to limit the transport from area to area as much as possible. They want to treat and assess these patients in their room, and with everything possible being done portable and of course under very clean protocols for staff that come in and out of the room. If you have smaller imaging units than the large echocardiography carts, and you can obtain the information that is needed, and that's all you really need to get at this point, as sick as these patients are and the treatments that they're already using. If you have smaller units, any of these systems that are smaller that can give you the information you need, they recommend that because it's obviously easier to come in, image on the patient, clean a smaller unit after being next to a COVID-19 positive patient. So it's a very good suggestion. If possible, there's obviously different staff, different rotations. You want the most experienced sonographers who can scan efficiently, accurately, and quickly in these type patient rooms if possible. But obviously this is going to be variable based on the what tier site they are, tier 3 or tier 2, and where it's located. So just be the person that you feel confident you can go in and get what is needed as efficiently and accurately as possible, and you're the right person. Always wear appropriate PPE. Do this based on your institutional policy, as there's some variances based on availability of the equipment. I just have to tell you personally, as someone who's been around lots of different things and did sterile scrubbing in the cath lab and in the OR, always do a personal timeout when you put on PPE. When you're putting it on, take very great care to put things on in the right order so you're not contaminating things as you dress, and especially after exposure. be extremely careful and do a deep breath and a personal timeout when you remove the PPE and take it off in the right and appropriate way and dispose of it in the right and appropriate way, so you're not contaminating yourself with one little slip where maybe you're getting a little too comfortable putting on the equipment, coming in and out of rooms, say in another week or 2 or 3 when you've done quite a bit of this. That would be the time that you might not take the time necessary. So slow down and take your equipment off very methodically and carefully. And if somebody can observe you, all the better. Read the guidelines. Minimize your time in the room. You only want to take the images and not do a lot of analysis. So you want a focused imaging protocol. You want a rapid acquire echo protocol that's probably already developed by your hospital or institution, and it's based on strictly on the need at the bedside at that time. If you want to use LVO contrast, or you need to use it and it's ordered and indicated, then as their video will show you, and again, I would highly address you viewing the video, have the contrast pre-mixed, ready to go, with a nurse available, who's donned and ready to give that contrast. As soon as you do your very few images, they should be ready to inject it. You take the rest of your images and then move on and get out of the ring. As I've mentioned, safely dispose of your PPE. Any analysis you should be doing later, whether it's offline software at the workstation, which is probably preferred because it's not the actual equipment, or certainly if on the equipment, then after you've terminally cleaned yourself, the equipment, and it's been removed from the room and in a safe area. So let's talk about myocarditis and the diagnosis and assessment as a disease process. Breaking down the terminology, we know from our medical terminology training, and myo indicates muscle. In this case, we're speaking of the endocardium or substrates of the myocardium. Card, of course, means heart or cardio-specific, and itis is an inflammation or condition of. So we have myocarditis, we have pericarditis. And just note that when you're looking at these patients, these are very areas of very close proximity. So you do have to differentiate a lot of different things, which mostly will be done by the attending. But you always want to be, knowledgeable as a sonographer to be sure that you're showing all the substrates of the myocardium through outside the pericardium and, of course, into any effusive area. So how's it defined? Here's an ESC page. Myocarditis is an inflammatory disease of the myocardium. Is diagnosed by established histological, immunological, and immunohistochemical criteria, which means it's all biomarkers in chemistry. What are the forms? We have idiopathic, which is, as we know, a lot of cardiac transplants come from folks who went somewhere or didn't go somewhere, and they kind of felt a little ill, much like this current virus, a little bit of a fever, didn't feel so good, and suddenly their feet were swelling. They got short of breath, palpitations, they come in the hospital, and their heart is very bad EF and sometimes very dilated. These people are very sick, as we all know. So some of the presentation is similar to what we see with just what we call idiopathic probable viral myocarditis. Then we have infectious. You can have different types of infections or autoimmune disease. In terms of age groups, it's not age group specific. Neither is this current virus. And a younger age group, less than 55, are relatively common, in fact. It is not a risk-based thing. It is definitely from some type of either immunosuppressive or immunological thing, or from a viral or bacterial or fungal infection. If they do poorly and there's no real recovery of the ventricular function, this group, of course, contributes greatly to the heart transplant group of patients. As with this, again, current virus, most will recover, and there's always going to be a subgroup of significant myocardial injury and heart failure that will have to be dealt with. Some of the causes, in terms of acutely, it's a cytotoxic storm, and it usually comes from some type of infection, as we discussed, or we don't know, idiopathic, autoimmune, and there are, I know a lot of people looking at myocarditis actually work in chemotherapy, some of the physicians who publish papers, and it can come from radiation therapy, chemotherapy, certain drug agents as clozapine and arsenic, and then chronic carbon monoxide, imbalance or breathing. Some of the lab results, they're going to look at all these, the practitioners and the attendings are going to get, of course, white blood counts, sedimentation rates, C-reactive protein, CPK, BNP for heart failure, and of course, they're going to look at the troponin levels as they can vary based on whether it's chronic or acute myocarditis. We'll talk about those types here in just a minute. Pericarditis, of course, they look for the ECG either way. Sometimes pericarditis, you see kind of that minimal, ST elevation along many of the leads. May or may not have a fever, may or may not have chest pain, may or may not have shortness of breath or night sweats. As far as the echo, I think most sonographers know that after discussing with the patient and asking about their symptoms and are they sleeping at night, and are they having some kind of weird variant chest pain that's nonspecific, we look at their pericardium, see if it's kind of thick and echo dense, comet tail artifact, those kind of things. And of course, we want to look for effusion, if there's anything in the effusion, debris, and of course, if there's any RV collapse or anything, to look for any signs of tamponade, which of course, as we all know, is more of a clinical presentation. If a patient's about to go in tamponade, there's usually a lot of evidence clinically looking at them. So that's not so hard to pin down sometimes. And a lot of times you'll be called to do an echo for this exact reason, to see if there's an effusion, to see if an effusion is larger to fit how this patient is starting to deteriorate. And of course, they may or may not have invasive lines. I know there's a lot of admissions with these patients, and again, it's going to vary based on the center that they're admitted to. Invasively, a lot of times if you have a compressive infusion or global that's pushing, on the heart from the outside like constriction, then you'll have equivocal chamber pressures if they happen to actually, do a catheterization. And of course, they're going to do chest x-rays. Myocarditis can be very different depending on the type that it is. If they're coming in acutely admitted, a lot of times they're so sick that a lot of it is easier to sort out as soon as they see the echo and see the heart function is really depressed. It's not always ECG specific. Generally, if they have this depressed left ventricular function, they're going to have, tachycardia, shortness of breath, dyspnea, and a drug 2 sats may be low. And of course, we'll be asking and trying to find out a history of some type of infection and their symptoms. And then what we're really looking for in the echo, of course, is the ventricular function on either or both sides. Specific signs would be similar to someone possibly having a heart attack or with heart failure that goes with acute coronary syndrome, a sudden death, and kind of hard to call it a symptom, but that is a specific, sign tied to acute myocarditis. A rapid onset of progressive heart failure symptoms, as we discussed. As you look at the hard dilated, very weak EF, just typical global strain. In this case, we go along with a bad EF. I'm not sure that would be sort things out. We'll talk about that a little later. And then non-specific are these people that come in, it's kind of come and gone. They have these variant symptoms. You have a ECG this, chest pain that, shortness of breath, not so big deal, not much of a fever, maybe a little tired, yes, joint pain, no palpitations. So they're kind of hard to sort out. They have non-concordant symptoms and test results, and these can be the people that have been kind of slowly going down the pike with this condition. That's why sometimes it's called kind of the mystery journey on finding out what's going on if they're not acutely ill. As far as definition, they talk about myocarditis in terms of being fulminant or non-fulminant, or in some cases acute. As this is it's a fairly old article, but basically they're just saying that the classification scheme makes a distinction between fulminant, which means a distinct onset of symptoms which are rapid within a 1 or 2 day period. Generally, when they check histology, it's tied to a virus, and acute myocarditis, which means symptoms, which means they've had indistinct symptoms. So in this case, they're calling non-fulminant acute, and it's something that's kind of progressive that's come on and on over a period of time. And they looked at, I guess, a whole lot of patients. And this is a little bit of a controversial paper, which we'll note back here in just a minute, that was readdressed later. And again, mystery disease, you see here's this is like a presentation. This is from the ESC report on myocardial, pericardial diseases, and some of the functional structural abnormalities on cardiac imaging, otherwise unexplained LV or RV structure or function abnormality, regional wall motion or global systolic or diastolic function abnormality, with or without dilation, with or without increased wall thickness, with or without effusion, with or without endocavitary thrombi. So you can see with or without is tied to many of these. So that's why getting through the pathway to the actual diagnosis usually leads to more of a histological or chemistry approach. So several years ago, I'm not an MRI guy, but I understand that I was lucky to work with some really, really good ones and was taught. But there was a Lake Louise meeting at a site where they decided on certain criteria. So basically, when should they use cardiac MRI for myocarditis? New onset or persisting symptoms suggestive of it, with dyspnea or orthopnea, evidence for recent or ongoing myocardial injury, which means dysfunction of the ventricle, ECG abnormalities, or troponin levels, or suspected viral etiology, which is what we're dealing with now, history of recent systemic viral disease, previous myocarditis, or absence of risk factors for CAD or a young person. How do they assess it using it? They're going to look at volume and function, stroke volume ejection fraction, their cardiac index, because as we know, obesity is tied to, a rougher journey or outcomes, LV wall thickness and mass, which of course is going to affect the diastology, and then myocardial inflammation and injury. There are things they can look at qualitatively, and then they give this gadolinium contrast, and they look at how fast this contrast permeates into the myocardium, and they can also see signs of edema, things like that, and of course the effusion. We'll have a couple of images here. Here's just a still image here from DeBakey, Medicine DeBakey in Texas, and it's just showing an example here using the gadolinium contrast, and here how it's permeating here and into this fundamental area head through the endocardium towards the epicardium. You can see how, there's a little effusion here. So this is like interstitial edema along with some contrast enhancement. So echo, what's the use? So here's a 2009 publication. This was just done in a clinical research journal, 10 years old or so. And there's just some good definitions here as far as where echo's role is. We're going to look mostly for left ventricular regional global dysfunction, as we mentioned. In one of the studies they mentioned here, left ventricular dysfunction was present in 69%, right ventricular dysfunction in 23%, and I guess what we call asymmetric or asynergic ventricular regions of dysfunction in 64%, which is relatively high, actually. The right ventricular function is an independent predictor of outcome. So this is important because there have been recent notes of folks being very concerned about the RV in the current situation, and there'll be a lot more information come out on that from the right entities, of course, at these larger centers and from the physicians on the ground. You do note the presence of myocardial interstitial edema, and then patients with fulminant, which is the more rapid onset egregious type, had near normal left ventricular dimensions, increased septal thickness, but they also had a much worse LVEF. And in this case, in this paper, they were saying that the fulminant or acute or more acute onset people had a better long-term prognosis. That was questioned. So before we look at that, we'll just note here, it's just Sean Teague had a little video on YouTube. So here's a good example here. You can see it's thickened. You can kind of see the speckly echo dense. And this is probably some of this interstitial edema. So if you're taking some quick pictures and you really notice some echo-free space like here, where at the base you really don't generally, this is like some non-compaction here, right? But down in these areas, you usually wouldn't see quite as much non-compaction. So you can see these kind of echo-free areas. You also see where it's bright and it's not bright. So this is very suspicious for people that have interstitial edema into the myocardium. So later, last year, there was a publication in JACC, and here they're looking at the same question because there were some opinions that varied. So they're saying fulminant versus acute non-fulminant myocarditis in patients with left ventricular systolic dysfunction. And their definition, fulminant myocarditis is a form of acute myocarditis characterized by severe left ventricular dysfunction, which require inotropes or mechanical circulatory support. So this is this acute admission person with these rapid onset symptoms and LV failure. This is a pretty large group of patients, and they all had proven myocarditis from histology, so they biopsies. So patients with fulminant, which is again these rapid onset severely ill patients, as you would think, even logically, much less scientifically, had significantly higher rates of cardiac death and transplantation. So that registry was very important in dividing more the progressive myocarditis patient, which they call, more the non-fulminant, and then the more, rapid onset, which is far more like the type of patients we're seeing now. And another description here, just to show you kind of the mysterious part when we're looking from an echo perspective, knowing that some of these folks may or may not get MRIs very quickly. Coronavirus fulminant myocarditis case review. This is just a single case, but it is in JACC. That's a pretty reliable peer-reviewed journal, to say the least. Here, chest X-ray showed enlargement. Not a lot of specificity. There was no coronary stenosis by CT angio, but here echocardiography revealed enlarged heart, marked decrease in ventricular function. LV EDD 58, that's not super big by echo dimension, but of course the volume would have told the story on that. LA, not incredibly huge, 39. RV 25, not incredibly huge. RA atrium 48, that's pretty big, so something going on there. But the ejection fraction 27% and a small effusion. So again, you may have either and, or some of all, but it's going to be variant. So the main thing for us is to get the pictures so that all this can be evaluated without sitting there and taking a million pictures while you're in the room with these patients. And we're going to talk about that at the end of the presentation. Here's just another example here of regional wall motion abnormality. This is the same patient. This is an interesting regional wall motion abnormality. You can see where Dr. Ade put the arrows there on these really regionally specific areas around the papillary muscle, like here, where it's just not quite coming in. And, as you can see, it's varying. Like this is contracting well, not so well. It's just variant. So this is what they're talking about. They're talking about these strange regional wall motion abnormalities. And it's just wherever the inflammation has gone in and where some of the edema has gone into the myocardium. And you can just pretty much see this area here. And he probably pointed, and again, here's the same papillary. Again, this is the same patient, but it just kind of sits there, see there? And he's got the arrows. So you can see how this is almost like dyskinetic, right there and right there at the papillary level in the base of the heart. Global longitudinal strain has been used, and this is not something, again, we're going to talk later about if you do this type of measurement, the how and the where and the when, especially the when. But there has been some publications. If you look at this particular video, you see the pericardium, I think right off the bat for sonographer, this is thick. You see the artifact. The heart itself doesn't look that bad. I mean, if you're looking at it, it looks fairly global, not highly, abnormal outside of the pericardium. And I put my arrows on there. And again, the pericardium, the posterior lateral part of the pericardium, I think is markedly notable as far as the thickening there. So, if you did an M mode or all those kind of things, you could do that. But again, I think if you were talking about a COVID-19 patient, you don't want to sit there and do a bunch of redundant imaging that really isn't going to add to what they need. So here's the strain on that. So this shows that even though we couldn't qualitatively see a lot of difference, there's actually a fair amount of global basal less kinesis than as you go towards the mid and the apical segment. So this can be hard to appreciate, and this is the value of strain. So it shows there is some dysfunctional difference between basal to apical regions that weren't qualitatively appreciated very well. And of course, we would look at the size of that ventricle and the EF and the stroke volume. Another example here. This is just a 4-chamber and a long axis view. Again, pericardium looks, I think, a little bit thick. And again, if you look at the long axis view, you kind of see a pretty big artifact coming right through here through that comet tail artifact. So I would say this one looks a little bit hypokinetic, but again, what I want you to get your mind wrapped around is In a normal world, you would take quite a few comprehensive image, use harmonics on or fundamental imaging based on how much, grayscale and detail you wanted. But you can certainly note once again, and this is this is a confirmed person with the myocarditis by histology. You can see again the differences in the thickening and echo density of the myocardium, even here traversing up almost like along the left anterior, descending up to the apex. And more than likely, there's some here too because of the cut of a four-chamber view across the ventricle. Yeah, you can see a little bit more here along this area. But that's kind of what you're seeing. So this patient was confirmed, and so when they looked at the global longitudinal strain before and after, this is a 3-month, I guess this is probably pre-discharge and 3 months post, there was some mild improvement in the GLS. And again, you see the more robust areas, they had a marked lateral hypokinesis with the inflammation, which we noted on the other echo. And then later, the GLS wasn't horrendously improved, but certainly better. But you do see the improvement here in the amount of strain. So if there's a way to do some of these measurements in patients with myocarditis, there's probably value there. We need more, studies, more papers, larger cohorts. And I'm guessing we will be hearing soon more and more about this from the big teams at Duke and New York and New Orleans and Detroit and all these places where they may possibly have this kind of data that they're collecting. Then some people have mentioned the epicardial strain because a lot of times it's in that edematous area where subepicardial you see lower strain values than you see on endocardial, which shows that there's a variance there. One caveat I have to that, and I'll thank Jeff Hill for pointing this paper out to me, is that there was a study done with the ASCs as a task force on multi-layer strain, epicardial strain, and basically what they show is, as we have had with all levels of strain, as we've advanced the technology and then studied it, is we have variance between vendors. So that makes it more and more difficult to have a standard mean value or change in value when we're looking at one data set here and looking at epicardial, transmural, and then endocardial strain. Now, they'll continue to work on this, but there have been some papers. Dr. Shaw mentioned that he had done a talk for ASC University that talked about where he had shown epicardial strain correlated well with his MRI studies. So, there's work out there. It's not something we're going to do, but because we're talking about myocarditis in a normal world also, this is some work that will continue and hopefully continue to improve to give us more data that echo can offer. And this is another paper, late detection of dysfunction with people non-severe acute myocarditis. So they're talking about the non-fulminant myocarditis. So they're saying often involves the left ventricular subepicardium. They looked at 50 patients. And basically what they showed was receiver operating curve analysis showed that subepicardial GLS displayed better diagnostic performance to detect sequelae of the myocardium as compared to regular endocardial GLS. So, we'll see. And this is how they're showing that here is the epicardial strain, endocardial strain. There's a number of programs that do this. I don't need to mention them. I've used them. But again, this is an expert operator, expert investigator site type of technology. But again, what we're going to talk about at the end is in a great world where you can collect just a few images, are we able to get the images that your experts could use retrospectively on these large cohorts and learn a lot from that will save lives down the road? So that's kind of where we're leading with this. So let's just move quickly into this. We're actually almost even wrapping up soon. So this came out like 3 days ago. This is April 6th. And this is from the Kaiser Health System. I don't think the hospital, but from the Health Network, yes. Published Scientific American. And the title's Mysterious Heart Damage, Not Just Lungs, Are Befalling COVID-19. This has been out, in fact, I would say over the last 10 days while I was kind of deciding on how to assemble this talk from home, what's out there. And I have to say I've probably seen something new every day or two. I've seen some mention of this in the videos that I mentioned at the top of this presentation that you should watch. That's why I'm not going to be the source for this conversation. But basically, a couple of good quotes from this article that you can look up online. As more data has come in from China and Italy, as well as Washington State and New York, more cardiac experts are coming to believe COVID-19 can infect the heart muscle. Initial study found the cardiac damage in as many as 1 in 5. That's pretty prevalent, leading to heart failure and death even among those who have no signs of respiratory distress. All the more reason to be extremely careful around these patients for quite some time to come, for all of us. The damage observed in COVID-19 patients could be from the virus directly infecting the heart muscle. Initial research suggests coronavirus attaches to certain receptors in the lungs, and those same receptors are found in heart muscle as well. Patients who had heart disease before the coronavirus infections were much more likely to show heart damage afterwards. But some patients with no previous heart disease also showed signs of cardiac damage. In fact, patients with no pre-existing heart conditions who incurred heart damage during the infection were more likely to die than patients with previous heart disease but no COVID-19 induced cardiac damage. So this is a completely different vision on things. And this is something that's going to be looked at for quite some time. And I heard some comments on a couple of these videos where they're expecting some data to come from this and care to come from this as this progresses. So basically on the patients, as what's appropriate for me to share that I've read, and it goes along with the imaging we're about to discuss, there are various reports of myocarditis in COVID-19 patients. The exact population at risk is yet to be well understood. There is no suggested echo protocol advice for COVID-19 induced myocarditis beyond your advised focus exam. Okay, so this is not a video on how to do a really long different exam, because there may or may not be myocarditis affected with these patients who have been admitted with significant symptoms. Elongated imaging time is not justified. Your safety, our safety is much more important at this time. Simple and rapid imaging with offline analysis of right and left ventricular size, function, and wall motion are definitely the most important thing they do need to know, with observation for pericardial or epicardial thickening, effusion. If there's tamponade, there's probably a good suspicion already, I would guess. Incidental observation of interstitial edema, as we looked at a couple of images there. Use of LVO contrast should be directed according to your institutional policy, the study itself as needed, or the physician in charge or who has ordered the exam or isn't present. Within a rapid acquire imaging approach, are there images which may be acquired productively and quickly that offer the most use for analysis if you have that capability offline later? A rapid acquire means that you have a short, effective protocol that within those images you could derive the maximum amount of information evaluation with the minimum amount of time, scanning, change of the probe position, and acquisition time. When I think of me doing this, I'm thinking about 2 minutes max. I feel very comfortable I could take all these images in 2 minutes or less. And that may not be the case with everyone, so this is something we'll walk through, because it depends on possibly what the need is of the sonographer. First of all, everyone these days should be very familiar with using electronic 2D plane rotation. This is much more effective, it's more efficient, it's more accurate, and you're not going to be moving the probe and readjusting the probe and rolling over the rib. Once you get a good apical four-chamber view and you have the apex centered as it should be on the sector, you should be able to take a very rapid scanning process using both X-plane and then electronic rotation and get a lot of your image very quickly. So you could start with a parasternal long axis, a view with a ventricle, turn on your X-plane. You're just going to observe the pericardium as we saw in some of those earlier pictures. Just what does it look like? Is there an effusion? And then just sweep your X-plane from the apex to the base. That'd be left to right on the screen. And then you'll have a number of images of long axis and all the short axis images as you scan across from the apex to the mitral valve. Very easy, extremely fast to perform. Then you could tilt down to your RV inflow view, turn on your X-plane, and you can acquire that view. You'll have both views, and from that view later, when you're out of the room, you can measure size, you can evaluate some of the functional aspects, You could probably perform, some of the strain and the TAPSE or whatever you need to do, and then look at the wall motion. You should not really need to perform any measures unless, again, your policy states that they want you to do a couple of things such as an M-mode TAPSE or something. I won't debate whether that's really needed or not. I'll leave that up to your team. Then go to your apical view. You can get your 4-3 2-chamber view using your iRotate tool on your cart or whatever vendor-based tool you have. You go to 4-chamber, rotate the scan backwards and get your long axis, get your 2-chamber. And if you have your apex focused on the sector, these should all be very relevant. You'll see the wall motion, you'll see the nature of the myocardium in terms of interstitial edema, and you'll move on. Then you can do a rapid collection if they think it's necessary. This is just something I throw in because it's very quick to do, is to get a pulse wave Doppler of the LVOT and or the RVOT, because you can get a direct cardiac output. So if you have a fair amount of MR or TR, you can get the effective estimated forward flow and a quick and rapid cardiac output that might be useful. So again, just leave that up to your physicians that you're working with. A 3D full volume of either chamber should be extremely doable and fairly easy. If the patient is ventilated and there's a possibility, if there's someone available to turn off the vent, you could get a fairly high frame rate data set with multi-cycle. I would say with these patients, many will not be on a vent. You'll still have these kind of subacute patients that are admitted. If they're coughing and they have a mask on, maybe they'll have a hard time holding their breath. But most of the new acquisition techniques using high volume rate, you can get a run of data sets, along ECG 5 or 6 beats, and do a retrospective capture of 1 beat that will not have any stitching and will probably have pretty good temporal and spatial resolution, good enough to get all of the ventricular information. So that would be my suggestion, is not to get hung up on breath cessation or apnea unless you have a very compliant awake patient who can simply stop breathing for a minute. It's always good to have apnea. In fact, if you're taking any other course in any other situation, I would be, telling you how to get a good apneic data set. In this case, I realize this is a different situation and your time in the room is the most important aspect besides the quality and accuracy of the images. Then you would go to your apical RV4 to get your usual free wall strain and TAPSE, which again you're going to do later, and then do your 2D focused RV view, which we're going to look at here shortly, and then use your iRotate or X-plane to get a good comprehensive. And I say this because these patients can have a lot of RV involvement. Some are having pulmonary embolus, they're having hypercoagulation, probably from back strain from the pneumonia in the lung, tissues. And so you do want to get a decent RV assessment, but not at the waste of incredible amount of time. That's why it's so important you use these tools, that you're not just angling and looking and going subcostal. You really shouldn't have to do a lot of that to get a really good assessment of the RV. And then 3D full volume of the RV in the same way. If you can get a good full volume of the RV, then you can get an incredible amount of information from your analysis program, or simply from a multiplane tool where you can put it in motion and look at it in multiple planes just like you would a CT or MRI. And then last, in the effusion, is it the debris in the effusion? Does it appear acute, chronic, large, small, loculated, all those kind of things. So this is what I'm talking about. When you set up your 4-chamber view, it's always going to be a little bit rounded in the 4-chamber view because the true apex is actually seen in the bicommissural 2-chamber view. So you want to kind of, discount between the two, but your goal is to line these up so that as you rotate electronically, or if you have a perfect hand, you rotate the probe manually because you don't have the electronic steering, which is pretty rare these days, you should be able to get a good 4-chamber view. You notice how centered the LV is? So slide your probe until this is centered at the expense of the RV. And then when you change your electronic steering, you can see here where it's steered here, you can steer it to a little bit to the right, and then you can steer it on around to your long axis view. You're going to be very quick getting these 3 images if you use this technique, and they're going to look better than when you manually move. So please use this. By the way, this is from, if you look this right here up on YouTube, she's got a fantastic video on all of these techniques that I borrowed this from because I was kind of short on time doing the talk. I'm sure She would not mind. Then we have 3D LVA or auto LV. This looks like a heart model picture here. So again, if you have that 3D data set, don't mess with it. Don't do it at the bedside. Acquire the data set, and then once you are offline or the card is terminally clean and you're in a different space, obviously if you use heart model, this can be run very, very quickly, particularly if you're using auto LV. These are very rapid and very well proven tools, and they give us a lot of the data we need as far as size. And don't forget, you can cut up a 3D data set and then measure the LV also as far as dimensions. And then here's a TomTech LVA. A lot of the other vendors have this. I've used both for years and years and years. And again, 3D strain is going to come on board at times, but you notice this heart does have a lot of mass. So there's a lot of LVH. It has a depressed LVEF. We have a good forward stroke volume. We don't know how much MR there is in this picture. Then we get longitudinal strain. This is not good. Circumferential strain is probably not as relevant as it used to be, but they're using it in research. So again, it just depends on what tool you have to use. Then if you have LVA, it's the one program that if you need LVO contrast to look at wall motions because the image is not good, and most importantly, the question is big enough for them to need this from the echo at the bedside, then you're going to be sure and have a team member there with you dressed in PPE, hooked up, ready to give contrast the very second you're ready for it after you get your rapid acquired 2D and 3D images. But you can direct this program to use with contrast. I believe Dr. Lang published this a while back, but this program does have a nice capability where you can look at it systole and diastole. You can adjust the templates based on what you see qualitatively with the contrast and adjust them, and then get your derivative numbers. So can you auto quantify with contrast? No. If you have a semi-automated and you're interacting with it as this program does, then yes, it works quite well. Then you think about your focused RV view. So this is where we have a regular 4-chamber view here where the RV would be cut off and the LV is more centered as before. We would simply tilt or pan the foot of the probe around and get the RV more in the center so you can see the full free wall. Just tilt it around here. I like to go to live 3D from that to ensure that I have the whole RV, or at least enough of it. It might be nipped here, but I have enough of certainly the endocardium to use it for a 3D acquisition. So we'll do your normal RV views. And then again, you want to use your eye rotate or use your rotation, bender program. Start out in your 4-chamber view, and you'll notice here how they're rotating here from 0, and then they're centering the apex from 0. Then they change the sector, and you're turning the knob to the left. This brings it around to the more lateral view towards the aortic valve view, like you see here, and then around to the RVO2 view. So you can see how to rotate, take a picture, rotate, take a picture, rotate, take a picture. This is a great way to get really high definition, 2D, high spatial, high temporal resolution pictures. Okay, so this is coronary sinus view there, right here on the screen. So this is a tool, I can't push it enough. If you want to do a rapid exam at the bedside and get a lot of information rather than just a couple of pictures, and it's okay by your institutional policy and you're okay as a sonographer, use it. Full volume capture, same thing. This is a good example where I've slid over and probably maybe gone up a rib or so to get the entire apex or wraparound apex here of the RV centered in the volume data set. I'm probably going to use a 1-beat HVR if I have enough, visualization to do that. We've already talked about apnea or ventilator arrest. It just depends on the situation. I would say if we're talking COVID-19, I would probably just go with what I can get with a 1-beat and not worry about that. A 1-beat retrospective offline is your best choice to basically take 1 or 2 data sets back to back, or do a long 5 or 6 beat run. And then you can go again back on the cart after you're out of the room, select the right, capture cycle, and then do the analysis from that. If you have auto RV, that's a new thing on Philips carts, and it may be on the others. I don't really know. It's pretty much where we used to do a lot of setting of the template. If you have a good RV 3D data set, and it has all the stuff in there like this, you optimize your image with your eye scan or whatever, all the information is there. Basically now if you run this program on the cart, it will basically do everything for you, and it does an amazing job with a good data set. and you get the size, you get a TAPSE, you get the fractional area change, you get the longitudinal free wall and septal strain. So, and here's your volumes, volume index, stroke volume, EF. I don't know how you can do any better than that. That's why I don't have any shame bringing up doing 3D for these patients, because if it's all said and done, if you could get a good quality 3D data set of the LV, a good quality 3D data set of the RV, you could almost say you have all you need very, very quickly to evaluate what they really care about, which is the function. Now, qualitatively looking at the walls for edema and those kind of things, 2D, of course, is going to be your tool for that thing. So for post-analysis, when you're out of the room, you can use your auto strain for GLS. I'm talking probably more to what your physicians are doing, possibly your fellows are doing at the workstation, or if you're an advanced sonographer, you may be doing as a team member on the advanced team. Since it's biplane, you can do that, of course, from your images that you acquired, hopefully from your ICE or X plane, because that way again you're cutting your scanning time. 3D full volume, and then you can get your LVA, your heart model, whatever tool you're using. 3D, the same thing. If you don't have the program to run anything in RV, the only thing I would say that if you have a 3D volume and you have a multi-plane program, you could still look at the RV in function in multiple planes. So it's still not a bad thing to have, even if you don't have the quantitative software. If you choose to do it and you want to get isolated cardiac outputs, you can put that in your report. I like doing it because it's very fast, but again, this will be based on your protocol at your hospital. If you have an approved 2D strain program and you want to do some work on these patients, and the sonographer has done the rapid acquire protocol to get the images that you need to do this, which are basically the same images we've already looked at, to be honest, then they may be able to use CPA or some other program they have on another vendor to look at epicardial strain and do some retrospective study from that. That's completely the call of the center, and I strongly would say this is going to come from our major centers that do this kind of work already, and they're going to share that data in cohorts. So, it's not a recommendation. I'm just saying that if you get the images, you'll have possibly what we need to learn very important information down the road that will affect our assessment by echo and what we can report down the road. And then note your interstitial edema. If you use contrast, was it used? Was it helpful? And of course, the wall motion. Final points. Basically from me and what we've talked about here, a normal world safe echo-based evaluation, which means the non-COVID world, or the world we had 2 months ago, for myocarditis by echocardiography would probably be a bit more comprehensive at baseline, using more images, 2D and 3D techniques, and possibly even LVO contrast, because it can be helpful for the interstitial edema and all that. But quite frankly, they would probably get a cardiac MRI in a normal world. Okay. Effusive presence, location, nature of the effusion or hemodynamic compromise has to be noted, of course. So don't spend all day looking at it, but if you see it as you're taking your other images, try to just have enough in the sector to show those things also. Don't do an extended protocol to look at the effusion when it's already in the other images you're collecting for left ventricular and right ventricular function, which is the biggest questions they're going to have. 2D, 3D strain imaging definitely have been shown in limited studies, various papers, to correlate with CMRI regarding abnormalities consistent with myocarditis. And there's certainly going to be an opportunity for retrospective research in larger cohorts that are able to obtain these images safely and quickly, and we'll be able to analyze them in the background. And I feel very certain we will see some of that a long time from now. Above all, strictly follow the new ASC COVID-19 safety guidelines. Read the document, get the chart on the wall, watch the video that I put at the beginning of the talk, asecho.org, COVID-19. Perform your imaging to address only the primary question the study is written for, with a rapid acquire focused echo exam, a more comprehensive color flow. If they have a lot of MRTR, you should be very clear on what they want or don't want at that point or that day or time regarding valvular correlation with the dilation or the dysfunction. If they don't really need a lot of PISA and all that, just be sure you're very clear before you go in the room what they expect you to acquire. Electronic steering tools such as iRotate can greatly reduce probe manipulation and your scan time. This is the time to start mastering the new world of electronic sonography using all the new tools, because we have tools now where you just hit a button and it automatically rotates to the next view, as in stress echoes. It's time to quit, not quit, but time to move on and use these tools, because in this era, scanning time is more important than it's ever been. And we can get the images, and quite frankly, a lot of times they'll be better. Quality 3D data sets, if effectively and safely acquired on these patients, of the left ventricle and right ventricle, enable software-based comprehensive evaluation of the structure, the size, and the function in the most time-productive way that can really be possible. Okay? So instead of thank you, I hope this has been helpful. I appreciate Philips having this as an open source video. This is what I spoke with him and requested. And it wasn't really started as a COVID-19 talk at all. I don't really feel qualified. I don't think we're deep enough in this. But having read what I've read and observed in the last 7 to 10 days, I felt like the content I covered was appropriate for me to present, and I hope everyone else will agree. And be safe, and please stay home. Thank you.
Well, Rick, I really appreciate you putting all this information together. And I know it was a bit of an effort, because I talked with you about getting this done pretty quickly. I think we all appreciate all the information that you've gotten, because myocarditis is not just a COVID issue. It's something we as sonographers need to be looking at in all of our studies that we do every day. I really, again, appreciate the effort that you took to gather all this information. And quite honestly, this is the first I've heard of the virus and its effect on the heart muscle. And so that was really, really an eye-opener. So we do have some questions that I've pulled out of the chat box here. And I think there's probably some more rolling in, but I'll cover the ones I wrote down that were back in the buffer a little bit. Rick, what do you feel is the value of RV systolic pressure when doing these myocarditis assessments?
You mean in terms of like from a TR jet? Can you hear me, by the way?
Yes.
Okay, just want to make sure. I didn't see a lot of publication on that, because it was more, they were almost everything was myocarditis, anatomically specific. I mean, if you have interstitial pneumonia, which is very different, than the usual crud that we get every year, they're going to have higher pulmonary pressures, and that resistance in the pleural wall is why it's so hard to oxygenate these patients when they're highly inflamed. And if you've seen some of these CT videos they've been putting out, it's very diffuse and very unpredictable on how and where it seats in the in the lungs. It's not like one particular spot. So yeah, I'm sure it's helpful, but I'm not sure it's, I mean, I can't speak for the physicians on the ground. I'm not in New York City, but I'm guessing that a lot of that is probably an assumed situation because of their condition. So it's always valuable, but I can't stress enough. And again, if you watch these ASC COVID-19 videos, they're really stressing not spending a lot of time on, stuff that is not going to add a lot at that time for that patient's treatment. They want you to have the least viral load and exposure as possible, because they're worried, and they should be. We all should be as we learn more. And so I would say, if you talk to your physicians, say, look, what do you want us to acquire? And really your question is not how important is RV systolic pressure. Your question is, should I be acquiring a TR jet? Well, if you turn the color on, they might say, well, just turn the color on and call it off. If they got TR, get it away for them. But definitely don't measure anything, okay? So you're really asking me a little bit of a pulmonary pressure question related to interstitial pneumonia. Sure, pulmonary hypertension is why they're dying. So is it relevant? Yes. But for a sonographer perspective of what we're talking about here, I would say if you're directed to collect your Doppler, then do so, but do that only.
Yep, great, thank you. And you know, to your point, we don't know what we don't know yet about this. As the months roll by, we'll find out that, hey, there are measurements that were more important than others. And as you were talking, collecting this data now is truly important. So the next virus that comes out, we know what to look for. So really appreciate your feedback on that. So a question that's not necessarily myocarditis, but someone was asking about using bubble studies for looking at acute right heart failure. Do you recommend that, or do you find that useful?
In the normal world, we do it all the time. I think if anybody's been to my course, when we're in the OR, we routinely do bubble studies. When we're in the TE lab, we pretty routinely do bubble studies. Not every doctor, but yeah, it's a no-brainer not to use a fantastic saline contrast study on the right side when you're doing it anyway. You know, so if it's indicated to do it, please look at the septum, but then I almost invariably will, the physicians know me, I'll use the zoom button on the machine and pull it back, and then I'll do an X-plane over the RV. And as soon as you show your anesthesiologist this in the OR, they'll never go back. It's a fantastic way to look at something very important as the RV function.
Well, in the olden days, that's all you had for contrast. You put some bubbles on the right side and see what you got.
Exactly. So yeah, it's a great thing. I kind of doubt in the current world you're going to be doing a lot of saline contrast studies.
Yeah, not with the amount of time you've gotten wanting to get in and out quickly. So I know it's almost impossible to get images of COVID-19 positive patients with myocarditis. However, have you heard if that appearance is any different than the myocarditis images you showed us otherwise? Is that the typical appearance we should be looking for?
I have not seen an image. I'm like you. I do expect that they are similar, but I can assure you the number one thing is going to be the highly dysfunctional ventricle, and it's probably going to have variance in the way the myocardium looks, and it's going to have variance in those strange wall motion abnormalities, because that was mentioned. You remember the second video I noted from the two Italian female physicians. There's some pretty good comments on that in the video that I noted earlier.
Yeah. And we have a question about using ECMO on COVID patients and how soon that's being done, if you have any comment on that.
That is a physician question. I appreciate the respect of asking me. I do know that FDA approved that, I believe, in the last 3 days. I would love to elaborate on my opinion on that, but you know, we have to stay in the right camp, and maybe the physician's asking the question. But we're going to see ECMO with these patients, yes.
Yeah.
So,
a couple questions that are in the QA box. Do you think turning off and on harmonics might help assess that the muscle and the pericardium? Is that something you would spend the time to do in this rapid assessment?
well, it's pretty easy to turn off harmonics. So let's not talk about time. I mean, if you're a newer sonographer, and I always want to relate to those folks because I realize it's not going to be the same two great sonographers doing all COVID-19. They're going to disappear. But so just know your machine. You know, quite frankly, this is a great time to use this challenge that we're in to know your machine. And so before you go in and do the study, go, okay, now here's what I'm going to do. All right. And look at the card and go, where do I go to turn off harmonics? Where do I go to do my X-plane? Where's that eye rotate button? You know, how do I preset my eye rotate? Have this completely worked out in your mind so you're like a machine when you walk in there and you know, you get that picture and you just bang out that protocol because it's so fast when you do that. So harmonics are easy to turn off, and sometimes people will suggest non-harmonic fundamental imaging for when you're looking at you know, natures of pericardial space, inflamed epicardium, just more grayscale. So do you need to do it? Not, possibly not. Some people keep the harmonics on and increase the compression. You get kind of a similar thing, but I think an experienced sonographer would say, you know, turning off and using some fundamental imaging can't hurt.
Great, great. We have a question here about those handheld ultrasound systems. This is specific to the Lumify probes. I don't know if you've got experience with that system, but I know you did in the talk about the utility of those handheld ultrasound machines. Again, easier to clean, get in and out quickly. But do you have any comments specifically about the Lumify?
Well, of course, if you have not seen how good the images are, then you're in for a nice present. They're incredible because we all like the images on our iPad, and that's how good they look. They're incredible. And I will tell you, I would highly suspect that any of the lead physicians who are on the ASE video, any at the bedside, the fact we do have a lot of anesthesia and POCUS people probably looking at these folks on and off during the night that we're not there, they would say that's a great tool. It's a desirable tool. And for them at their level and the fact they're treating and know what they need to know that's not maybe as specific as what we want acquire on a regular echo, like for some of this other analysis, they would probably prefer that because it is all you need, honestly, to see, just look at it and see what you need to see as far as the RV and LV function and any change, such as they give inotropes. You know, do you want to take a quick look with that just to kind of see if it looks like the LV is responding well, look at the wedge pressures and the volume loading.
Okay, great. Rick, I don't know if you can see the chat window.
I'll
do you want me to read?
Let me look here.
Yeah.
Let's see.
If
Here
not,
we
I
go.
can try to read them off to you.
I can now, yeah.
Okay, great.
So where should I look?
Probably scroll to the most recent one.
At the top or bottom?
Bottom.
Bottom, okay, sorry.
I picked the questions from above earlier.
Okay, so I see the bubble study part. Pattern of global hypokinesis diffuse cell. I mean, that's exactly what thanks, Chris. That's pretty much exactly what I would expect to see, and you're right, it has been. And you guys understand that I've probably read the same things you haven't seen what you have. But again, when we're doing a webinar on something that's so poorly understood, and we all understand that we have a lot of expert physicians that are seeing this times 100, I try to be careful on, doing more than us just elaborating on what we expect we may see. It really is about getting the images. Once the images are there, we can sit and get coffee in a safe place and even remotely and look at these and learn from them as a team. But in the room, we need to be very, very efficient.
Absolutely. Just scrolling back here. Someone is asking what value indicates a thickened pericardium. And I know you pointed out the echocardiographic features, the bright thickening, the sort of comet tail artifact where you get that reverberation. Anything else you would want to elaborate on that?
I think the change in gray density is probably more important. And a lot of times what people will do is they'll turn the compression up and then slowly back down the master gain. Because as you do that, you'll keep the grayscale. And if the pericardium just seems to not change much as you keep decreasing gain, that's kind of a giveaway. The comet tail and the artifact, all that is a giveaway. But the thickening, I would think most people would think, it's thicker than 3 or 4 millimeters. That's pretty thick. A pericardium is almost indiscernible when it's normal. So I would say 3 millimeters or thicker. I'm just throwing it out there, but I feel safe with that comment.
So here's a question I'm not sure any of us can really answer, but Ashley comments that a lot of the sonographers in Indiana have been laid off or not being used, and they haven't hit their peak yet. Would your expectation be, as more knowledge of the heart's involvement in COVID, that we may see some of those people coming back to work quicker than others?
Well, I hope you'll all be back at work as soon as it's safe to do so. And again, I could say a lot, but I'm not going to jump into that train. But there's definitely a lot of things going on the pharmacology side that is hopeful. I mean, we're all hoping for some good things besides actual immunity. So that's institutional. So as long as you have a lot of high acuity, if you're a larger hospital up there, they may be doing more of the bedside folks like the anesthesia, POCUS people, fellows and all that. So it just depends on, I don't know what center you're at, but I mean, that would have a big effect on that. But if you're asking 6 months from now, when we have found a way to safely come in with our masks and gowns and do echoes, a little bit more, comprehensively, and the patients are like over the COVID, or they're now immune because they've lived and they're over it, will there be more echoes done in follow-up? I've heard some hints that because they're now seeing this inflammation in the heart, and as we saw, even isolated, and look, we need a lot more data to say that's a huge trend, but the answer would be yes. If we end up with a large population of people of all ages, and quite frankly, unfortunately, these will be younger because the older ones are not doing as well. If you have this inflammation in the heart and the lung and you're old, you may not be the person that does so well with this. That's kind of what we're fighting. So my guess is, I think we may see a lot. I hope not, but I believe it's possible. Yes.
Yeah, I think it's safe to say, as we learn more about the heart's involvement with this virus, it's really an unknown, but it's scary where that could go.
Yeah, a little bit. Yeah.
Have a question in the box. Has there been any information shared yet about whether you see right heart involvement first, is the left heart involved first, or can just be whichever?
No, they mentioned both, but Dr. Cadorio definitely mentioned that they were seeing some right heart. So that's why I was hit this so heavy in this talk. Do not isolate just the left ventricle. You want to look at both of them as comprehensive as you can. So I really beat my head on the desk about, what would I do if it was me and I wanted to be in a hurry and get everything I needed to get. And that's where I really started thinking about get a 3D and do a lot of eye rotate and do it quickly and get a lot of information, because the RV is so strangely shaped, you can miss stuff. It's almost like ARVD. It's always way up in the apex or in a weird spot that if you just do a couple of quick images, you're going to miss that until they have VT or die, so you don't want that to happen. So it's the same thing here. You want to, look at the RV, but they're very worried about the right ventricle and the things that I've seen. So let's just consider them both very important.
Great. So we have a question about looking at the lungs during an outpatient asymptomatic echo.
Only if you know how to do a blue exam. I mean, if you know how to do a blue and they've approved you to do that, to look at those B lines, which is very diagnostic, that's already been pretty well reported. I'm guessing they probably get that in the ER though, from the frontline POCUS, because they're obviously ER physicians are all getting pretty well trained in POCUS and for the blue scan. But I can't answer that for you or your institution, but I would guess probably it's based on your qualification and your training.
Yeah, I totally agree. I think talking it over with your institution, with your medical director, what do they want you to do? And again, asymptomatic doesn't mean they might not have the virus. They just might be showing it yet. So you treat 30%. Everybody like they've got it.
And the other thing is, do you have that probe? I mean, this is not a transthoracic echo probe. This is a linear probe.
Correct. Yeah. Correct. And do we have any information about how soon after someone presents with COVID that we're seeing effects in the heart? Is it? I haven't seen any data myself. I've been watching everything I can. No. Have you seen anything? Okay.
No, there's nothing public. I think even people at the Montefiore in New York would say they don't have enough information. They can't even get any sleep.
Yeah.
But how quickly? No, I would say though that if you're going to just postulate on it, probably very fast, because they're going to be a lot like these virals. The others we talked about. They come in and they deteriorate super quick. And my guess is as we learn more, is that these people that deteriorate even more quickly could be because they have both lung and heart. But we don't know that. We don't know. Nobody knows. I mean, we just don't know yet.
And so another question that I think is hard to answer, what's the opinion on echoes in hospitals on their outpatients? People who are not positive, should we be doing fast, limited scans on them? My opinion, again, that's a discussion you have to have with your medical director and your administration. What are your thoughts?
No question. In fact, again, I'm going to point you back to the ASC COVID-19 video that they just did 3 or 4 days ago. I think it was Monday. In fact, I watched it. They talk about this. Most hospitals are not doing a lot of outpatient echo at all. They're not doing stress echo right now. They're doing only what is absolutely necessary for patients that are in need.
Yep.
everything else. And so I can tell you one thing, back to the other girl's question, or Ashley, is that when this does get to where people can come in and have echoes again, I can't imagine what the volume will be because of the backup. Wow.
Yeah, I
Yeah,
totally
there's going
agree
to be
with
jobs will be available.
Yeah, you'll be getting some overtime maybe. So Rick, I really want to thank you again for putting all this together. We're getting near our end time here. I know it was a lot of work to put this together. There's a lot of digging you had to do to find information. But as always, you've come through. You've been a mentor to me over the years. You're the guy that taught me 3D. And I really appreciate you putting all this together for our customers.
Well, thank you. And above all, be safe, stay home. And this is going to be a very once in a lifetime Easter. And for those that are along those lines, and I just pray that you have a blessed weekend, and thank you for being here.
Yeah, absolutely, Rick. Thank you so much. I'm going to pull up a screen here really quickly. So this screen talks about some additional education opportunities. You'll get this information in an email, as well as a link to watch this recording. It'll probably be available late next week. But if you're registered for the event and you've attended here, you'll get all this information in the email. But I just wanted to go over it with you to make sure you hear it. You can look at additional education offerings. We've got a lot of information that we're able to provide via a virtual setting like this. Our clinical specialists are still out there teaching and training. So if you have needs, want some more information, please go to the website and check that out. You can contact your clinical service specialist. And additionally, here's an email address that you can reach out to us if there are things you're interested in, things you need. Again, this is recorded. You'll get a link again late next week to access that recording. And I really want to thank everyone for attending. And I'm going to double check here really quickly if there's any last questions. Great. Like to see a webinar on 3D. And we're seeing what we can put together for folks. But we do have a lot of Rick's courses are available via what we call distance learning. So again, contact your clinical specialist and they can talk to you more about what's available. All right, everybody, with that, we're going to go ahead and close out. Again, thank you so much. And those of you on the front lines, I really, really mean this with all my heart. We appreciate everything you're doing out there. Old guys like me that get to sit and do education in my spare room. Remember what it's like to be out there in the field. And I really hope you guys stay safe and take care. Thank you so much.
Thank you. Bye-bye.